I'm really glad to be talking about this topic that I'm going to address, and especially to be talking about it at this point in our TED Talk, because the prior speakers have pointed to a number of things that relate to our theme, which is the unchangeable realities at the edge of life. And I can't think of a more challenging, unchangeable reality at the edge of life than the fact that we die, which is what I'm going to talk about. The other thing that the other speakers have talked about is the importance of conversation. And so I want to focus in on what it's like to have conversations about dying. And the third thing that the other speakers have talked about is community, beloved community, and how to build that. And as a pediatric oncologist, which is what I do, I've become very aware of the ways in which we can be alone in dying because of our fears and unable to talk about it. And so moving into conversations about dying, especially with children and their families, is something that I've begun to think of in my own work as my version of brain surgery. And the reason is this. When you do brain surgery, not that I've done a lot of it, but I've watched it, one of the most important things about it is that when someone's brain is in front of you, the stakes are really high. The second thing about brain surgery is that when you're doing it, you have to operate on the brain that's in front of you, not the brain that you wish was in front of you. And so the vessels are what they are, the tissue is what it is, and you have to do your surgery on the brain that's in front of you. The third aspect of brain surgery for me that's made me use this comparison is that you have to pay attention. And just a moment of inattention to what's going on in your operating field can lead to irreparable harm. And the same is true in some of these very sensitive conversations. The last thing about brain surgery that makes me like this comparison is that you have to know the limits of what you actually can do with your operation. If a person has a brain tumor, you want to take it all out. But very often, there may be a point where to cut any more out, to push the procedure any farther, is actually going to be to harm instead of help the patient. And you have to know where those limits are. And so when I approach conversations like this, I approach them with the metaphor of brain surgery. The stakes are incredibly high because each child that's facing death is singular, shows up only once, lives a life, and it matters how the child's dying goes. So the stakes are quite high. When I walk into the room to talk to a family, it's also the case that I must start with whoever it is that's in front of me, wherever they happen to be. Not start my conversation where I wish they were. And it's often the case that I have in my mind, from my experience, a fact in my head. And the fact that I have in my head is that I am quite certain that this child is in the last part of his or her life. But it's not necessarily the case that the truth of the family's experience and the truth of the child's experience maps onto that fact. And if I deliver the fact just as a fact, bluntly, and without paying close attention to what else is going on inside the room, I can actually carry a family farther away from the truth of their life instead of helping them move to a deeper understanding of what's going on in the room. And that's the part of the surgery procedure that requires exquisite attention to what's going on in the room and to who's in the room. But no matter where the patient and the family start, I have a defining centerpiece that helps me keep in mind what I'm hoping for the child and the family. And it's this, that the last moment of a person's life is still a moment of life. And I want it to be lived as well as possible, whatever that means for the person and the family in front of me. And so my goal in conversations like this is to listen and try to find out what that last moment would look like if lived well for this child and this family. And I try not to come in with a presumption of what it would look like for me. And that's where I need to lean in softly and listen with a willingness to be changed. So what does this actually look like? It doesn't have to be sophisticated. It can actually be quite simple. And there are times in these conversations where the slightest move can make a world of difference. She was 17, and she had metastatic bone cancer with large tumors growing in her lungs. She and her father had tried to get to a place where they knew what to do next, and they were finding it very hard to get there. Her mother had moved a lot farther along in accepting what was going on. And this I only knew from a distance, because the primary doctor had let me know just in the course of going over patients that we all had at the time. So I was on service, and it was the weekend, and she came into the emergency room having difficulty breathing. I had met her a couple of times before, and I knew this little bit about her. But beyond this, I knew very little about the truth of her life, how she was actually experiencing this. So I walked into the room, and I greeted her, and I sat down, and I said, "It looks like you're having trouble breathing." And she was having a great deal of trouble. So I gave her some morphine to make her comfortable, because when you're in pain or distress, it's very hard to think, it's very hard to talk. When she got to a place where she was comfortable, before I could make even introductory small talk, she said, "I'm going to another institution to get an experimental therapy that you don't have in your institution." Well, the fact that I had in my mind is that I knew she was actively dying. But the truth of her experience that she was telling me clearly by introducing this into our conversation early, and by the way she looked at me and the way she held herself, was, "Don't go there." And so I paused briefly, trying to assimilate this. I don't always think as fast as I should on my feet. I'm trying to get better at this, and it's very much of a growing process, because this is hard to learn. But her dad turned to me. Her dad had brought her in. Her dad turned to me and said, "Doctor, what do you think about that?" What I think about a phase 1 trial, which is what she was going to do, which is a toxicity study, given where she was at in the dying process, was one thing. But when he asked that question, once again, paying attention to what's in the room, she looked at me, and I could tell from her look that what she was saying is, "Don't you dare take this away from me." And so I listened. And before responding, the dad saw her look and said, "Wait, let me get her mother on the speakerphone." So she got her mother on the speakerphone, and we caught her mother up on things that were happening. And I responded to her question. or to the dad's question. Not by answering his question, what do you think about this phase 1 trial, but with a question of my own. Because what I had begun to realize is that she had to keep in control of this conversation, and she needed to be the one who paced the conversation. And so I asked her a question. I said, what was it like driving from home to the emergency room? And she said, it was horrible. It was scary. How long did it take you to get from home to the emergency room? 45 minutes. How far away is the institution you're driving to in the next day? Several hours. I worry that this trip's going to be uncomfortable for you. She begins to nod and to think. And I see her eyes start to get wet. And so she asked me a question. Well, if I don't go, what's going to happen to me? And for the first time, a window has opened up for a conversation that she's not been able to have yet. And this is one of those moments where I know we either do this well and pay close attention and respond to her as she paces the conversation, or I can say something that completely blows this conversation out of the water and we never make it where she's trying to get. And so she says, what'll happen if I don't go? I look at the dad and I see that he's started to cry. And so by paying attention in the room, I know we're almost there. And then the mom on the speakerphone asks the question, because she also knows the answer. And she says, how long is it going to be, doctor? How long? And my patient stiffens. And I can see that this is the question that was not to be asked. And because she tells me that with her body language, I look at her and I ask her, is it okay if I answer that question? And so I ask her permission. And she pauses, and then she leans back into her hospital bed. She begins to cry, and she says, yes, you can answer that question. And so I say, I would think in terms of a week. Dad starts to cry. And the mom says, baby, I can't do this alone. I need help. Dr. Barfield, is there any help that we can have at home while we do this? And I look at her again and I say, is it okay if I answer that question? Because this is her conversation, and that's the key. And she nods, and I say, I could set up hospice for you, and they could do a great deal to help you with comfort while you face this hard thing. Would you like me to do that for you? And she nods, and she and her father, for the first time, look at each other knowing that she will die soon. And they've got a plan now for how this is going to happen that doesn't involve a multi-hour trip to another institution to get a phase 1 toxicity trial. And so, I give her a tank of oxygen, I give her multiple doses of morphine to help her through the night, and I set her up with hospice for the next day. I stand up, I kiss her on the forehead, and I say goodbye. They drive home, and what I know is nothing about the content of their conversation, but I know that for the first time, they were able to talk with this unbearable reality having been brought into the open, but without causing rupture or harm to the way that they talk and approach these sorts of things. And that night, I know, though I don't know the content, that she and her family were able to be together with this reality, and that she was not alone. Alone in silence, which can be very isolating, but rather able to talk. And the next morning, they woke up together, and she died. It matters greatly that it happened this way. And one of the things that I've learned with these conversations and with our approach to dying is that there's actually a great deal of work that many of us need to do in the context of this last part of our life. And it's very hard to do it with some of the distractions that are available these days in medicine. It's very hard to talk about dying. Doctors find it very hard to talk about dying. We're going to die too. But there's so much that can be accomplished. It may be reconciliation. It may be an expression of love. It may be simply not being alone. And it's also possible that we can be surprised. I'm going to give you an example from a man whose son died of neuroblastoma several years ago. And he and his wife had gone through a similar process to what I talked about, and were at home, had a last meal with their son, and everyone was around while he died. And I said, "Tell me more about the experience." And he said, "Ray, in the middle of grief, in the middle of a grief I never knew was possible, I was completely surprised in this experience by the word that comes to my head when I try to describe it. Beauty." Thank you.